educate our children. And the reason for the choice of this topic was to empower our young adults so that we build a healthy nation. We start with the first question. Why is it important to address STI in adolescents? Dr. Taruna, please.
So, a very good afternoon to everybody. Truly, ma'am, it is very important to address STDs in adolescents because the burden of the disease is very high. WHO says that the incidence of STDs is as high as about all over the world 1 million per day. So that is a very high number. And if we talk of India, it is about 1 lakh per day. So maybe we do not realize, but the burden of the disease is very high. And since we are focusing more for adolescents, so in adolescents, it is a bigger issue because adolescents are more vulnerable to this disease because of the risky sexual behaviors that they elicit, because there is a lack of knowledge about prevention of this disease, and because there is limited access to healthcare. Not a limited access because the things are not available, but more so because the adolescents, there is a lot hesitation about talking about this issue so as to maintain the confidentiality. So this makes them more susceptible to contracting the infection, in diagnosing the condition late, and having more complications. So it is very important to be able to diagnose it.
Very rightly said, Dr. Taruna. It is the non-judgmental behavior of the society at large which should take precedence over anything else. When they come to us and we can, even if they don't give a history of a sexual contact, but we are aware, so let us keep it to that only. So my second question will be to Dr. Vandana. How will you screen for STI in adolescent walking into your clinic with complaint of discharge per vaginum or a pruritus, private parts, dysuria? Like I said, she may not give you a history of sexual contact.
That's very right. But nowadays, these girls have become very smart and they do give a history. The moment you ask, they say, yes, we are into relationships, and they don't shy away. Somehow, because of maybe sex education in schools or what. And we should know what is STI and what is STD. STI is the infection, and STD is the disease which occurs because of the infection. So these children, they are very aware, they Google everything, and then they come to you. So according to CDC guidelines, all sexually active females under 25 years old should be screened annually for STIs, including chlamydia and gonorrhea, with a consideration for screening young males as well, particularly those at high risk. And focus is for females under 25, and over 25, it is risk-based. Next. So male screening is, while not as universally recommended, young males with risk factors like multiple partners or that is emerging high risk behaviors, they should be the ones who are screened. And the girls are given an opt-out basis that if they deny, only then we stop at investigating them. Otherwise, they need to be screened for STIs. And the healthcare provider should be very considerate to them about going about and these tests and counsel them very properly. And these are the most commonest cause of white discharge would be, I would say, bacterial vaginosis and trichomoniasis. And other diseases are not very far behind because they usually engage in very high risk behavior of having multiple partners. They do not realize the importance and they do not realize this scare this can cause. Syphilis, gonorrhea, chlamydia, genital herpes, and genital warts are not far behind. So we have various diagnostic tests for them. For syphilis, we have VDRL, that is non-treponemal, and RPR, and specific treponemal test would be TPHA, FTA, ABS, and dark field microscopy is directly you observe the parasite on the chancre exudate. So the more specific would be when you directly visualize, and the Treponema pallidum heme agglutination test is definitely more specific. For gonorrhea, it is wherever NAT comes, that is nucleic acid amplification test, they are the most specific ones. They are PCR based. Gram stain and microscopy culture are others. So it can be done on blood serum, urethra, cervical, rectal, pharyngeal swabs, and urine and pharyngeal swab is already there. So NAT is very highly sensitive. For chlamydia, there are NAT, PCR-based tests like LAMP. These are all nucleic acid amplification tests. LAMP, TMA, SDA, and DFA tests. And they can be done on endocervical and urine swab. And for genital herpes, serology, that is PCR, HSV, DNA detection, and viral culture. So for herpes, what I found very interesting was that we have serologic test, we have virologic test, and then we have the test in serology, the tests usually come later. The virologic tests are more sensitive and direct, if you can see on the slide. That is the most sensitive because that comes even before the serology becomes positive. The other important thing I realized we are used to doing, even I have been doing, IgG and IgM. They say IgG and IgM is a serologic test. It does not differentiate between HSV1 and HSV2. So it should not be done. Although we do not have any other test in our country which is very specific, and it has to be type specific. All serology tests.
We will be discussing that, ma'am.
It'll be discussed later on.
Yes.
It'll be type specific, and even virologic tests are type specific. So we treat according to, because 2 is genital region, so that is more severe, and although HSV1 is not far behind. So trichomoniasis and trichomoniasis, we have NAT, again, wet mount microscopy, and genital warts, we have pap smear, and confidentiality and counseling is a must. Opt-out testing I talked about, non-invasive testing, always urine-based, and self-collected vaginal swabs. Partner treatment is very essential to reduce the frequency of the disease, and promotion of vaccination in HPV and hepatitis B, and we have to take history for sexual contact and assess behavioral risk like substance abuse.
So it was an eye-opener for me too when I read that all females under the age of 25 should be screened for gonorrhea and other STDs. Number 2, yes, ma'am, every year. And number 2, we have a non-invasive test. If she's hesitant, we can always go in for urine and swab collection test. Dr. Fotedar, since you said you are the only odd man out, but very important for us, how will you screen an adolescent boy with similar complaints? And what is your take, and how will you counsel? Because boys are generally more rebellious than girls.
Thank you, madam. And as a matter of fact, most of it has been covered by my colleague, Dr. Saab. And what I would like to emphasize upon that how to get the history as the first part, and then later on we'll be talking. And establishing a rapport with an adolescent is the most difficult of all the treatment parts. Establish better communication with the subject by addressing his apprehensions. I have come across situations where an adolescent boy came to me 4 times, and each time he told me very different story. He could not tell me what his problem was. Sometimes he came with headache, sometimes he came with yahan pe dard ho rahi hai, wahan pe dard ho rahi hai, and all in a gap of 2 days. And then I could judge that there is some problem is there. He is apprehensive, but he is unable to really communicate to me that. So I took him into confidence. I said, look, now at this time, his elder sister was with him. And I just asked her to go out. I have to talk to this man. And at that time, I told him, look, I'm like your father, no doubt about it. But I understand you want to tell me something, but you are unable to tell me. I am a medical practitioner and I have got a policy of medical conduct that I am not going to tell anything that you confide in me to anyone else unless you tell me or unless it is legally required. So this assurance when I gave to him, it worked. It worked, and he said, sir, mere se galati ho gayi. I said, fine. I was not sitting in a judgment seat. गलती हो गई I am no judge of yours. मैंने कहा कोई बात नहीं. What next? So I have gone to a CSW and now I am afraid कि मेरे को कोई problem तो नहीं हो गई है. मैंने कहा, are you having a problem? He said, no, I am not having a problem. I asked him, did you use a barrier for that? No, sir, I did not use a barrier. Why did you not use a barrier? Sir, it happened just like that. We were friends, we were drinking, and we just decided that we will go, and that is how it happened. And the situation was that she didn't have enough of them because all of us were there. And we were 4 or 5 of us. Fine. So you want me to do the tests on you? Then I explained to him in all details that what are the possibilities, and you believe me, all of you, he burst open. He burst open the moment he felt that this man is going to help me and he is definitely my well-wisher, and he opened. And the next day, 6 of them came to me. All 6 of them who had used the barrier.
Very effective counseling, sir.
Right? Can I have the previous slide, please?
Yeah.
Yes. So interview him isolation without the presence of parents, because he has a guilt feeling कि मेरे माँ बाप ने मुझे कुछ कहा था कि ये नहीं करना है, मैंने फिर भी किया. एंड उनके सामने ये बच्चा बहुत छोटा पड़ जाता है कि वो माँ बाप मुझे सवाल करेंगे कि डिड वी नॉट टेल यू, एंड घर में जाके मुझे म्यूजिक फेस करना पड़ेगा. सो इसलिए इसको इंटरव्यू करना जो भी है पेरेंट्स के बगैर करना है. एंड वी हैव नॉट टू बी जजमेंटल, एज जस्ट नाउ आई टोल्ड यू, एंड देन ब्रीफली शेयर द डिफरेंशियल डायग्नोसिस, टेल हिम अबाउट दिस थिंग. वी कैन ऑल्सो शेयर अबाउट स्टैटिस्टिक्स which assures him one thing कि he is not alone. उसने ही सिर्फ गलती नहीं करी है. Like madam told me, 1 लाख लोग रोज होते हैं, 1 साल में होते हैं यहाँ पर. So all of them are not unlike him. They are all like him. So गलतियाँ होती हैं. So now here am I to help him out and give him time to think about it. Don't hurry him. जाओ बाहर, दोबारा आओ. I asked him to go again, come again, and that is when he did it. Next slide, please. So examination should include general examination, including swellings, lymph nodes, rash, in the conjunctiva, fingers and toes for Whitlow marks, and various sites for injectable drug use. And that's also very important, not that much in girls, but in adolescent boys, you will find all those marks on the arm where they can be using the drugs. Then local examination for inguinal skin ulcers, rash, eruptions, infestations, pigmentation and tenderness, and inspection of shaft of penis, glands, mucosal aspect of the pubis, frenulum, meatus. These are all general examinations that I, as a male pediatrician, would do him. Scrotum swelling, epididymitis, we have to palpate it. We have to find out tenderness is there or not. Ulcerations on the skin of the scrotum. Then anal opening for rashes, for being patulous, for any discharge there, or circumanal condylomatous or circumanal ulcerations are there. These all have to be looked for.
Doctor, we'll move forward. We're short of time.
Okay.
Gee, sorry.
Next, please. Next.
The protocols for screening.
Okay.
Doctor,
So
was
we have
in just 2 lines, what will be your protocols for screening?
The protocols, I would really go for this thing that all the children all the adolescents who have come, they will be screened for all the diseases, including HIV, including VDRL, including gonorrhea.
So what specific test would you
we would
write?
go for a VDRL test in the first instance, and if there are indications, we'll go for TPHA, right? And at the same time, urine routine examination is also taken, routine culture is also taken, and smear examination for gonorrhea is also taken. And if the inspection has got certain ulcers there, so we can take a direct smear for herpes simplex, or else we will go for, as madam said, the other tests which include PCR and antibodies for IgM and IgG. And these are the things.
Thanks, Doctor. Dr. Vandana, what is your take on the ethical and legal considerations in treating adolescents with STI?
I'll give an honest confession. I did ask Dr. Geetendra about it. Because even I was of the opinion, if there is a sexual contact in an adolescent, POXO Act applies to it. If they are coming for STD, he also is of the same opinion. Age is no matter. Ideally, we should. But we have to really work on the society and think that what are we reporting? What are these? Recently, there was a young girl with pregnancy, and we sent the notice to the information to the police station, and the police station people did not know what to do. I told them, you just sign the paper and just give it back. You don't have to do anything. You inform the child welfare committee, they'll take care of it. But that fellow was so scared, I'll have to take action, madam, main nahi kuch karunga. They do nothing. So this is but for this also, whatever may be the guidelines of, but POXO Act would apply if there is a sexual contact in our country, adolescent. For parents, it is informing the parents. We can always have an option. We can talk with the child, take the child into confidence, and then talk to the parents. Because until unless the child agrees to it, है ना? Again, I'll give an example of a girl who came, got an MTP done, and then her parents came and she told me, ma'am, उनको बताना नहीं MTP के लिए आई थी, मैं किसी और काम के लिए आई थी. But I sent her out. I could not, as a mother, I could not do that to her parents. I talked to them कि अगर तुम्हारे बच्चे ने गलत किया है तो तुम क्या करोगे? तो first response was हमको मारेंगे. Then I said अगर मारोगे तो तुम्हें कुछ नहीं बताएगी, फिर मैं भी कुछ नहीं बताऊंगी. है ना? Then they understood. Then they understood that they need to understand. जो हो गया वो हो गया. They have to keep it behind.
So, Dr. Vandana, in our country, POXO
And
is
sexual-
which any sexual activity which is involving minors is considered statutory rape requiring mandatory reporting. But you need to have, as clinicians, as one of the guardians of the society, a balanced approach that prioritizes healthcare access over criminalization. We have to decide ourselves whether if I go and she has come to me voluntarily, if I inform the police, it will be a setback for all of us. So this is where we need to strike a balance.
The other way around, Dr. Deepti, if there is a legal consequence of it, it will be a setback for you. You can't take that call. You can't take that call. It has to be a universal information to the police. They have to do nothing. They just have to inform the Child Welfare Committee. But the POXO Act should give us the liberty to inform the Child Welfare Committee directly. So let them take action, whatever they want.
नहीं मैम वो तो हम करेंगे बट एनी गर्ल हु कम्स विद अ वैजाइनल डिस्चार्ज एंड यस इन्फॉर्म करना मैम दैट मस्ट है बट मैनी ऑफ अस डोंट डू इट मैम फॉर अ डिस्चार्ज और अल्सर So, Dr. Saurabh, we would like to know, as a very eminent and leading skin specialist, what is your take on the diagnosis of herpes and management?
Yeah, thank you. Thank you, ma'am, for inviting me. It's good to speak to a different set of medical fraternity. I'll tell you whatever I see incorrectly coming from gynae references, and I feel very good to be able to address that. So I don't need to see those references. It should be handled at your place. So that is what the whole talk today should be. This is something, again, a lot of doctors even don't know, right? Forget about the clients not knowing. Most of our people who engage in sexual activity actually wrongly believe that condoms are safe sex. It's safer sex. There's an R added to that. There's a difference in the safe versus safer. Safer basically means it still gives you STDs. So there's so many people who feel they are socially conscious, responsible adolescents, and they almost feel violated when we say कि तुझे STD हो गया. कहता कैसे हो सकता है मैं तो condom पहना था, right? So there are two groups of STDs, right? So there are something called secretion transfer STDs, which are definitely prevented by condoms. There's no doubt about it, right? Gonorrhea, HIV, chlamydia, trichomonas. Next slide, please. And these are the ones, unfortunately, which are not stopped by condoms. What's molluscum, syphilis, herpes? And now this is the primary reason why you see this more, right? At least I see this more as compared to something else. Because they say कि ऐसे कैसे हो सकता है? Because this is not secretion, this is skin to skin touch, which then means that we have something called as pubic skin STDs. Root of the penis, pubic mons. इतने STDs हैं जो हम देखते हैं कि what's यार pubic area में क्यों हुआ? Penis पे क्यों नहीं हो रहा? Inner thighs पे कैसे हो गया molluscum? क्योंकि condom पहने थे. So this is a very important message. I feel all of us should tell this to everyone else. Condom is not a license to do anything that you want to do. It still gives you a risk, right? Next slide, please. Let's talk about herpes. I see this so commonly, right? Let's talk about how do I diagnose, and I'll see the mistakes which most doctors do even. Please go ahead, please. Next slide, please. Next slide. Yeah. Diagnosis, I'll tell you my short ways of diagnosis. One point for all of you people here. Don't, I'm saying this in capital letters, don't rely on investigations for herpes. Straight, okay? Don't fall into the trap of investigations. You will always be very wrong, right? Most of us will be very wrong when we rely on investigations. Herpes का test कितना भी कर लो, textbook में आपको कितना भी लिखा हो, serology कर लो, ये कर लो, वो कर लो, this is going to be both false negative, but more importantly, false positive. I'll tell you the problem with false positive. I'll tell you how we do this. Always look for grouping of ulcers. Grouping is central to herpes. वो कभी दूर नहीं होता. ऐसे गुच्छे में आता, we call it bunch of grapes. Alright? It's always excruciatingly painful. वो हर 2 दिन में आपको आएगी कि मैम फर्क नहीं पड़ा. जब वो ये आके बोलती है, आप बोलो भाई तेरे को तो herpes है, बस बात खत्म. There's nothing else on this, right? Always multiple, never single. Always recurrent, always prodrome. वो हमेशा वही कि पता नहीं ना 24 घंटे तक वहाँ पे ना ऐसा लगा कुछ हो रहा है. Right? She can feel it coming. Ask her that. She has felt it. She has felt tingling. She has felt कुछ चल रहा है. You know, this feeling is very classical herpes, right? There's usually going to be some kind of discharge. You don't think of discharge as primary there. Don't treat the discharge. Discharge is a secondary response to herpes, right? So it's not a discharge disease. Next slide, please. Okay, next slide, please. Okay, this is where the trap is now. Next, just go ahead. Yeah, not required. I want to finish there. That's itself. Forget Zank smear. Forget HSV serology. We'll talk about serology right now, but let's forget it. That's the practical take home on this. Let's go ahead. Go ahead, please. Next slide. Next slide. One second. Just stay on the first one, HSV1 versus HSV2. Okay. So caution. Now the problem in most of the labs is they do 1 + 2 together. I'll tell you the problem here. I'll give you the exact incident. Today morning, Max Hospital, I was there. I vividly tell you this. Female, male, both coming, right? Female shows me first, she has herpes labialis, right? Lip herpes. She's got it since she was 11th standard, right? She's been a patient like that. She gets a boyfriend. She marries the boyfriend. The husband now is coming with a genital herpes. Yes, now see the problem here. He's been to 4 dermatologists, including a government hospital. Everybody said, you've had a sexual contact. I'm talking the male, right? Now the male is really almost crying कि मैंने तो कुछ नहीं किया. ये तो मेरी only partner है, मैं तो love marriage करी थी. Female बोलती है, सब डॉक्टर ने बोला इसने बाहर कुछ किया है. See the complication here? Now there's a fracture of the relationship just because they think the male has had sex outside. Now see, you know what's happened here? Okay, the male is, I can tell from the eyes कि वो सच बोल रहा है. मैं तो आंखें देख के बोल देता हूँ कि सच ही बोल रहा होगा, जल्द भी हो सकता है, but it's my judgment, right? फिर कहता नहीं यार मैं तो कुछ नहीं किया. फिर मैं बोला तूने ओरल सेक्स किया था इसके साथ? कहती ओरल सेक्स तो किया था, right? Now say where the whole twist is now. The female is now giving HSV1 on the genital of the male. So this is called HSV1 herpes genitalis. Not HSV2 herpes genitalis. Now, for the first time, the female said, this makes sense. Both of them get very relieved, though I may be wrong in all of this, but they finally possibly have an answer. Peno-oral sex is very common. Let's not ignore it. Let's not think it is under the carpet. Bahut common hai. Herpes, HSV1 is very common on the genitalia. Let's not only look at sex kiya hai kya. Oral sex is enough. Yeah, next slide. Okay, third slide, let's talk about this. This is what, again, a lot of mistakes happen. When we talk about IgM HSV, can you even see this? It comes, last slide, please, last slide. Previous slide. Yeah. IgM can take as much as 10 days to even come. And by 10 days, the herpes is actually over. So you are actually getting IgM when there's no herpes. राइट तो जब हर्पीज है तब आईजीएम नेगेटिव आ गया तो हम क्या सोचते हैं अरे आईजीएम भी नेगेटिव आ गया मतलब ये तो हर्पीज ही नहीं है. Are you with me on this? Yes. So this is where the mistakes happen. Let's not get into this. It's going to be troublesome, right? Next slide, please. Okay, this we know. Okay, IgM positive, IgG negative is okay. Now IgM positive, IgG negative, there's no problem on this. IgG positive and IgM also positive. This is called non-primary first episode. एक बार समझा रहा हूँ. 1 second, just previous, please. There's something called non-primary first episode. You know what's that? I have sex with someone, I get herpes inside, but I am now silent even with that herpes inside. इसको बोलते हैं प्राइमरी साइलेंट एपिसोड. ठीक है, बाद में मुझे एक्चुअल डिजीज हुआ 4 साल बाद, वो तो मेरा फर्स्ट एपिसोड है, लेकिन पहले हो चुका वो नॉन क्लिनिकल था. इसमें आएगा आईजीजी प्लस आईजीएम टुगेदर बोथ. यस, नेक्स्ट. Okay, this we know, IgG positive, this I'm not going to speak about. Treatment, it's very easy. Acyclovir 400 TID, 3 times. That's the best drug we know, right? Even in pregnancy, should be easy to give, right? Famciclovir, valacyclovir doses, I don't want to discuss because that's common, right? So let's only speak about the errors that happen. Next slide, please. Acha, one more thing. Topical therapies don't work. Don't give topical acyclovir. It's a myth. It does not work. There's only one place topical acyclovir works: recurrent herpes labialis, and that too not the first episode. When it comes second and third time, then you don't give them oral acyclovir, you give them topical acyclovir, right? Next slide, please. Next slide. Next slide. Next slide. Next slide. Go ahead. Go ahead. Go ahead. Go ahead. Go ahead. Yes. Okay. Next slide. Next slide, please. Next slide. Next slide. Next slide. Yes.
Just one second. Yes, just one you want?
This is good. This is good. This is what I want. This is good. Now, this is again something I really want to speak to you about. I see a lot of your fraternity, again, no ill will on this, making a mistake on this, right? So let's speak about this. Viral positive, don't do anything after that. Wait. Okay? Do a TPHA. FTABS, don't do. Forget FTABS. Okay? Do TPHA. If both are positive, you have a case, refer to me. End of story. Yeah? Or you can treat yourself with benzathine penicillin. Okay? Anyway, that was just outside. Okay. Now, if I treat, 3 महीने में वापस VDRL करना है, ठीक है? VDRL negative नहीं होता 3 महीने में. It only reduces by 4-fold. It's still positive. You again repeat it, it's 6 months, 9 months, 1 year. कभी ना कभी तो negative हो जाएगा. When VDRL is negative, TPHA still stays positive. TPHA never becomes negative. Very important. That does not mean the disease is there. We call it a scar of syphilis. पहले syphilis हो गया, वो रहेगा TPHA. Unfortunately, it will never be negative. इसको treat नहीं करना है. ये वहम है. हमारा भी डॉक्टर का भी वहम है, पेशेंट का भी वहम है कि ठीक नहीं हुआ. Yes, go ahead. This is again important. Viral positive, but TPHA negative. इसका भी कुछ नहीं करना है हमें. Usually it is 1:8 से कम होता है. Clear? Yes, go ahead. Treatment is, yes, please. Everyone who's got viral positive, TPHA positive, is an active disease, get a spouse testing done. Pregnancy is one of the commonest causes for false positive VDRL. We many times jump to give benzathine. In pregnancy with a VDRL, no, do that. Only if a TPHA comes in a female, then you rush in and give them benzathine. Go ahead. Always. One off the cuff, right? Candida does not need partner treatment. Okay? This is a common thing I see again. Female with recurrent vulvovaginal candidiasis, वो मेल खा खा के परेशान हो गया कि कितनी गोली खाऊं, ये तो ठीक ही नहीं हो रही है ना, क्योंकि मेरे से थोड़ी ना उसको हो गया वो. It's a commensal and it's giving her the disease. Yes, go ahead please. Benzathine and doxy is what we give usually. Yes, go ahead please. Okay, watch, go ahead. Okay, I'll tell you how to treat what's my last slide. Okay, imicimod is something that we give very commonly, right? We give it in the night. One precaution, please. It's very important, okay, to be really in a topical जहाँ है वहीं लगना चाहिए. और उसके बाद I tell the female to just abduct, okay, खोल के रखना है pelvic area को, हवा आने देनी है, dry रखना है, and then she should close her thighs, otherwise वो इधर उधर लग जाएगा, सब ulceration हो जाती है. Next. Podophyllin, a bit risky. I think you should keep it to me, right? But I'll give you the information. This is a bit more toxic than imicimod. I would do this at my clinic. Patient को बुलाना पड़ता है. Very ऐसे नहीं तो बहुत ही एक खराब काम हो जाता है. But it's a good drug again for genital warts. Go ahead. Cryotherapy is again nice, but genital में ना थोड़ा cryotherapy is tough. आसपास थोड़ा सा इसमें कोल्ड स्प्रे ज़्यादा लग जाती है, तो आई एम नॉट इन फेवर ऑफ क्रायोथेरेपी. गो अहेड प्लीज. कॉर्टी लेजर्स कर सकते हैं, वी कैन बर्न इट ऑफ. नेक्स्ट स्लाइड. दिस इज समथिंग अगेन नाइस. दिस ये आप लोग भी कर सकते हो. वल्वल वॉट्स, प्रेगनेंसी, TCS गुड इनफ, सेफ. यू कैन ईजिली डू दिस. वहीं पर लगाना है, इट बिकम्स वाइट, यू नो इट्स वर्किंग. Cryotherapy is good in pregnancy and TCS is good in pregnancy, right? I think that should be good enough for me to tell you. Thank you.
Thank you.
So do you apply some numbing gel before you go for TCA therapy?
Sorry.
Do you apply the numbing jelly before you go for TCA?
Never. No.
Okay. Thank you, sir.
Dr. Taruna, what will be your take on treatment guidelines for herpes simplex?
I think sir has covered it so beautifully. He has cleared so many doubts of ours. we will encounter HSV in two situations: as a gynae patient, and in pregnancy it is a little more common. He already said acyclovir is a safe one. Only thing we might have a little confusion as when the lesions are a little atypical. We might be confused whether it is actually there and whether we should. I think that time we can take their opinion also. And pregnancy, I would say, little more vulnerability during pregnancy because HSV is very common, and once it is there, it stays as inactive virus in the body and can again elicit. I think recurrence is much more common as compared to what we actually realize it also. So it always stays there and it can throw recurrent episodes, and that is why we have that concept of suppressive therapy, so that the recurrences are less reduced. And I was reading that recurrences means in a year as much as about 6 episodes.
Yeah. So the guidelines say that if you have more than 6 episodes in a year, we usually give 1,000 milligrams of valacyclovir once a day. Right? If it is less than 6 episodes, we can go with 500 milligram valacyclovir once a day. 1 year. Okay, 1 year is the time for this. 1 year के बाद हम बोलते हैं कि बंद करेंगे. उसके बाद recurrences फिर होते हैं, लेकिन the worst phase of herpes is the first year of herpes. So we are supporting them in the worst phase, and then when the disease is kind of going down naturally inside, तब हम उनको छोड़ देते हैं. फिर वो बोलते हैं 2 episode हो रहे हैं साल के, चल जाएगा. Right? But फिर भी अगर अगले साल में भी ज़्यादा है तो फिर हम 1 साल और खिला देते हैं.
And one more thing of active herpes in pregnancy, the mode of delivery, I think we all agree that it is by cesarean because of the risk of neonatal herpes, because it affects the skin, mucous membranes and eyes in the baby.
In this, it's always better to give prophylaxis in the last trimester to allow for a normal pregnancy to happen.
Have you actually seen it?
Yes, we do. Unfortunately, we do. We see it more in varicella. Honestly, the systemic manifestation. Herpes, a bit rare, but yes, we have seen encephalitis, yes.
Dr. Saurabh, for the active phase, how long is the duration?
For the first episode of herpes is the worst episode of herpes. So usually about 10 days.
10 days.
And
Ma'am, acyclovir, sorry? Valcyclovir BD.
so, Dr. Taruna, what is the role of biopsy in diagnosing STI-related dermatological conditions? When will you do a vulval biopsy?
As Sir said, that there are very few clinical, it is only mainly on the basis of seeing the lesions that we should be able to make a diagnosis. Serological criteria and biopsies are kept reserved for few lesions, maybe when the presentations are atypical, like in molluscum, in warts, like Kaposi sarcoma in HIV. So I think these 3 are the skin condition, the skin biopsy conditions where we can do, if that too when the presentation is atypical. Otherwise, with the presentation itself, we should be actually able to pick it up.
So, Dr. Saurabh, do you want to add
Molluscum
something to
lesions
this?
also.
When are you going to target a skin biopsy?
It's been 17 years since I've not done a biopsy
Oh, great.
on the genital. I've just do it only one where many warts, not many, occasionally HPV 6 and 11 can turn carcinomatous, right?
Yes.
So this is called Buschke-Lowenstein tumors, which are warts turning to cancers. So that was the only indication where we actually did it to prove cancer, and it proved to be cancer. But for an STD, as I said, no investigation. Let's take home that. SIF experience, and this is the only place where your experience counts. Labs don't count.
Great.
Ma'am, molluscum, I had a slide on molluscum, but because it was a male slide, so I think that was removed. So, कि आप male genitalia नहीं दिखा सकते. That's banned in this hall.
We are not dealing with that.
मैंने आपने निकाला ना. तो मैंने बोला ये slide बदल कैसे गई? मैंने तो दी थी, बताओ, दी थी ना मैम? Ma'am, molluscum ka ma'am, the best therapy is we take a needle and we scoop the whole thing out. It comes as a small papule, right? And then we burn the root with a bit of radio frequency machine. ये सबसे सिंपल है ना, तो हाँ ठीक है फिर तो है ना, मतलब हम पेशेंट को ऐसे मतलब we can escape, right? So Actually, I had a slide. So anyway,
Sir, I think we should
इसको हम
be having.
फिक्स्ड डग इरप्शन बोलते हैं. फिक्स्ड डग इरप्शन बोलते हैं. It always looks like herpes. Okay, I'll tell you the difference. मैंने अभी एक्चुअली बताया था, but I'll say this again. क्योंकि मैं पढ़ाता हूँ तो मैं टेबल ही बना देता हूँ आपके लिए भी. हैं तो एक साइड herpes है, एक साइड फिक्स्ड डग इरप्शन है, right? Both are recurrent. Both come on the exact same site on the genitalia. There's only two differences. Herpes always grouped. Fixed डग इरप्शन is always a single big one. ठीक है, तो एक बड़ा जख्म देख लिया, बड़ा है, बहुत दर्द कर रहा है, तो हर्पीज हो ही नहीं सकता. सेकेंड, फिक्स्ड डग इरप्शन ऑलवेज गोइंग टू हैव अ बिट ऑफ पिगमेंटेशन अराउंड दैट अल्सर. वो ब्राउन होगा या ब्लैक होगा, हर्पीज कभी ब्राउन एंड ब्लैक नहीं होता. दैट्स द ओनली एंड वेरी इजी वे टू डिफरेंशिएट. और दूसरा, उसको पूछ लो कि देखो लूज मोशन हुआ था क्या, बोलेगा हाँ बस यही लूज मोशन. दिस इज टिनिडाजोल एंड ऑर्निडाजोल.
Okay, we'll move on to Dr. Sharma. What are the current CDC guidelines for treatment of chlamydia, trichomonas, and gonorrhea?
See, Dr. Vanna has already taken the patient in confident and diagnosis has been done. Now it's hard to treat. I think all gynecologists know very well. For chlamydia infection among the adolescent and adults, doxycycline is the best drug, 100 milligram BD for 7 days. But nowadays I feel that so many gynecologists, everybody is writing doxycycline, and most of the people are resistant to it. The better is levoflox and the azithromycin. Azithromycin has become common because of the COVID. So much azithromycin people have taken, and everybody take their own. That is the one thing. Alternative regime is azithromycin 1 gram orally in a single dose, and levoflox 500 milligram. And in pregnancy, azithromycin single dose is enough. And alternate, we can give amoxicillin 500 milligram orally 3 times a day for 7 days. And gonococcal infection, first ceftriaxone is the best drug, 500 milligram IM in a single dose. Or otherwise, if the chlamydia is not excluded, better to add doxycycline 100 milligram BID for 7 days. And for gonococcal infection, if there is ceftriaxone is not available and you want to give oral, then the azithromycin and cefixime is the best drug. Otherwise, we can add gentamicin single dose. And otherwise, I don't know, one more thing I just want to, clindamycin has a good role or not, especially in gonococcal. And next is trichomoniasis, all joles, just now, metronidazole, tinidazole, 500 milligram, 2 times per day for 7 days. And among men, only a single dose is enough, 2 gram orally. And tinidazole, 2 gram orally in single dose, alternative, that's the alternative regime for we should treat partner always.
These are from CDC guidelines 2021, and it has not been changed for over so many years. The standard
It's the
remains the same. Yes.
Guidelines are same.
What are the current guidelines for post-exposure prophylaxis of HIV in adolescents?
Actually, I have gone through the whole literature and I did not find exact dosages of the drugs which have to be given for adolescents. There were drugs available for adults. I have pointed out, can you please display that
Drugs.
slide?
Yeah. Next.
No, next please. Yes. This was one of the things in which he has said that more than 40 kilograms weight, and we can give this combination of dolutegravir 50 milligrams, amitriptyline, I am not even able to pronounce it, and tenofovir alafrite 25 milligrams. This is a combination available as a single tablet, and it has to be taken for 28 days continuously, daily once. And after this completing this course, the adolescent has to be advised to undergo a test after about 3 to 6 weeks once. If that turns out to be negative, the repeat test has to be done after 3 months. If that also is clear, then only we can tell him that this post-exposure prophylaxis has probably worked. So this is the protocol that is available right now. I think if Dr. Saab can add to this about the drugs. No, my problem, madam, is that when we do it for children, we have a different denominator in terms of the amount of serum that he has, the amount of fat he has. So this cannot be extrapolated to an adolescent which has got a different physiology. So that was the reason I did not put it like that, because I need a confirmation written particularly for an adolescent. I went through PubMed also, I did not find. I'm sorry for that.
Now we move on to the last question for the panel. Dr. Sharma, how will you differentiate between physiological and STI-related discharges in adolescents?
See, in routine practice,
When will you ask for FIR? Information to the police.
see, routine, everybody gets a patient for white discharge, and all females, they come with the white discharge and they keep on saying, बहुत पानी जा रहा है, बहुत पानी जा रहा है. And some of them, if you just take a good history, that is most important. History and clinical examination. Like color, consistency, then order, then what are the symptoms, what is the amount, and microscopic findings. I don't think everybody is doing that microscopic finding part.
No, those who are Shada Ma'am students are doing wet and dry smears in their clinics. Yes, yes.
If the patients are more, then we are not doing. If patients are less, then we used to do it. That is also one criteria. The color, if the physiological discharge is there, it will be clear, white and slightly milky. But if there is an infection, the color is changed either to yellow, gray or frothy. If the consistency will be thin, or otherwise in the infected case, it will be thick, curdy, purulent or frothy. Then odor, there will be no smell will be there. But if there is infection, there will be foul smelling, unpleasant. And what are the symptoms? If the patient has come with the discharge, he just asks, is there any itching is there? Is there any burning, any irritation? If it is not, no need to worry. If all these things are there, dysuria, dyspareunia, and abdominal pain, then we have to treat the patient. Otherwise, amount. If the patient, if you ask the history, are you going to change panty regularly, so much discharge? If she says no, only I am not changing at all, just relax, it's a moderate, no need any treatment, you have to just consult the patient. If excessive associated with the inflammation in the infected, microscopic, if you're taking discharge and if you're doing the test, if it is lactobacilli is present, it is a simple, or if you're putting potassium hydroxide, your normal saline, if something has come like clue cells comes, otherwise trichomoniads have come, then naturally it goes to the bacteriovaginosis. And very most important is, if we put potassium hydroxide and there is a pungent smell comes, then it will go for a bacterial vaginosis.
Fishy smell. Even otherwise also there's a lot of fishy smell in the bacterial vaginosis discharges.
That's important.
And we don't have KOH in the OPDs usually.
Yeah.
So there's the AMCEL diagnostic criteria of bacterial vaginosis. You would like to elaborate on this?
That will be in discharge thin homogeneous. Positive whiff test means amine order produced by the mixing 10% of the potassium hydroxide solution with vaginal discharge sample. Clue cells will be present. Vaginal pH will be more than 4.5. 3 or out of 4 criteria must be met. Accurate to make the diagnosis of bacterial vaginosis, and it is highly significant.
Thank you so much to my esteemed panelists.
Thank you very much that you've gone through this particular module and have liked it. By addressing the critical aspects of adolescent reproductive and sexual health, their diet, their exercise, and the bone health, we aspire to contribute to development of healthier and more informed generation. We invite all stakeholders to join in the endeavor as we collectively strive to create a supportive environment where every adolescent can thrive, prosper, and contribute for Viksit Bharat. Dhanyavad.